Hello once more, welcome to Lab 3, and today we are going to talk about blood pressure measurement both at rest and while change in our posture. So let's talk about the presentation outline. As usual, as we have been discussing throughout these lab demonstrations, that why we want to take blood pressure and why we want to learn that skill. This is the first part of our discussion. Then before jumping on to the technique of taking blood pressure, I want to discuss a lot of terms which are displayed on the screen because I feel that for this practical and the practicals which are coming up, you should at least be aware of the basic definition and the concept behind these terms which are going to be used on a regular basis. Then, the things which are highlighted in red, point number 3, 4, and 5, are the objective of this practical. Believe me, to develop the skill of taking blood pressure is the most important part, not for only this lab 3, but for whole of the exercise testing and prescription lab. So I will try to explain it in a lot more detail, and you are going to practice from this lab onwards at this 1 month as many times as possible, so you should be really good at taking blood pressure. Then we will try to see what are the blood pressure changes if you change your position from standing to sitting or from sitting to lying down position, and interchange of these positions. And at the end, I'll just talk a couple of minutes about the data sheet which you need to fill at the end of the practical. So let's start with a very key note which is essential for this practical and the practicals which are coming up. Please make sure that you use units on all the values which you are going to write on the data sheets now and during your practical. For example, with blood pressure, always write millimeters of mercury mmHg, and if you are writing anywhere the pulse rate or the heart rate, please mention beats per minute, because without these units, all the numbers which you wrote have no value, and you will can see deduction of points in case you miss those values. So make it a habit of writing mmHg after every blood pressure reading and beats per minute after every heart or the pulse rate reading. Now, I always want to talk about blood pressure, its exact definition. The first important thing you need to understand is that this pressure is a lateral pressure. This is not the forward pressure. I agree that as the blood moves into the vessel, there are two pressures which are exerting. The one which is forward, that's a forward pressure, and we are not measuring that pressure. But once the blood moves forward in a vessel, it exerts pressure laterally like this as it moves throughout the vessel. And that pressure we are measuring as blood pressure, or we commonly talk of as blood pressure. So in one line, if you want to summarize, lateral pressure exerted once the blood moves in a vessel is known as blood pressure, which we are measuring here. Now, there are a lot of things why we need to know about blood pressure. The important point is because once the blood is circulated throughout our body, it reaches various tissues at different perfusion pressure, and that pressure is important for the oxygen exchange. So you need to have the right amount of pressure. The second problem is that if the pressure is too high, it will damage the end organs which it's reaching, and it also damages the blood vessel in which it is traveling. And if the blood pressure is low, it is insufficient to provide apt perfusion in terms of oxygen and nutrients to the surrounding tissues. So because of all these problems, we want the right pressure throughout the pumping of the heart to nourish the organs as well as to avoid any damage to the surrounding tissues. Now, blood pressure depends on two big factors. On the right, you have the cardiac output or the CO, and on the other side, you have the TPR, or the total peripheral resistance. I wrote those definitions because these factors directly affect blood pressure, and a change in the value of these factors change the value of blood pressure. So the heart of this definition is that cardiac output is the volume of blood pumped by heart each minute. So a total of 5 liters is what is heart is pumping at rest. And if you devise this formula of cardiac output, it's a product of heart rate and stroke volume. So heart rate is depending upon the parasympathetic supply, stroke volume depends upon the sympathetic supply, and if both of them increase, cardiac output is going to increase and blood pressure is going to increase. On the contrary, if you talk about TPR, it is the total peripheral resistance. And as the name suggests, it is the resistance or the pressure which stops or occludes or impedes blood from moving into the vessels. So the more is the obstruction, the more will be the pressure, because blood have to exert more and more pressure to overcome this and move. Now, I just want everybody to remember 2 points from this slide. That the cardiac output is responsible for maintaining systolic blood pressure, and TPR or total peripheral resistance is responsible for the maintenance of diastolic blood pressure. So any factor which affects cardiac output is going to affect systolic. Any factor which affects TPR is going to affect the diastolic blood pressure. So CO, systolic, TPR, diastolic blood pressure. Right. Now let's quickly talk about in one line about all of these terms, which sounds really simple, but I just want you to be aware of them. So if we talk about the cardiac cycle, it's a combination of electrical and mechanical events which occur during one heartbeat, and that includes systole and diastole. So electrical impulse is generated first, and it causes contraction of the heart first, which is depolarization, ventricular contraction, and then there will be relaxation for the filling of the blood, and that's the diastole. And a combination of those just happening every beat is known as cardiac cycle. If you talk about the systolic blood pressure, it is the maximal pressure during systole or maximal pressure during ventricular contraction. On the contrary, if we talk about the diastolic blood pressure, it is the minimum, the lowest pressure during the diastole, which is happening during ventricular relaxation when the heart is getting filled up with blood. And if you take a difference between the systolic blood pressure and the diastolic blood pressure, that is your pulse pressure. And the last one is the mean arterial pressure, which is actually, as its name suggests, mean is average. So this is the average pressure during one cardiac cycle. And if you want to calculate this, you will put the diastolic blood pressure and take a third of pulse pressure and add these two components. So the idea of this whole slide is that once these terms pop up at different times during your discussion, whether it's in the theory or in the lab, you should be aware of deciphering these terms and should be aware of one word or a kind of a one sentence definition. So we have the cardiac cycle, systolic blood pressure, maximum during systole, diastolic blood pressure, minimum during diastole. Take a difference, that's pulse pressure, and whatever average pressure is happening during cardiac cycle is the mean arterial pressure. Now, it's extremely important to know what is normal, and then only we are able to talk what is abnormal. So this classification is the one which has been taken from the American Heart Association, and it's the 2019-20 classification. And the one which is highlighted in green, as you can see here, if your systolic blood pressure is less than 120 and diastolic is less than 80, then everything is normal. So everything is normal. The things highlighted in green, less than 120 systolic, less than 80 diastolic, it's all normal. Now, if your systolic is between 120 and 29 and the diastolic is still less than 80, then it is elevated blood pressure, but it's still not high blood pressure. But you know what, it's in the pre-high condition, so it's highlighted in yellow. Now, if your blood pressure is more than 30, or it's not and it's or, if and your diastolic is more than 80 but less than 89, so 80 to 89, it means you have hypertension. I agree it is stage 1 hypertension, but it is hypertension. And as it goes on increasing, if it's 140 or more, if it's 90 or more, believe me, you have stage 4 hypertension and you have to visit a physician very, very quickly. And the last one, highlighted in red, this is the red flag sign or a danger sign. If your blood pressure is systolic is more than 180, diastolic is more than 120, this is an emergency. Consult your doctor immediately because you are at really high risk of getting a stroke at any point of time. So be aware your cerebral vessels can burst, and don't try to do any exercise. Try to consult your doctor as soon as possible because you are under real danger of getting a stroke. So if you summarize this whole slide, less than 120, less than 80, everything is fine. If it's more than 130, you have hypertension. And if it's more than 180 systole, more than 120 diastole, believe me, it's hypertensive crisis. Now, speaking of hypertension, just a quick points I want to highlight here. If the chronic blood pressure is elevated at rest, this is hypertension. And what is hypertension? We have just talked. It is a risk factor for cardiovascular diseases, and the important point why we are discussing here in this lab is that you should identify those individuals who have chronic elevated blood pressure at rest, so you don't want to put them into any treadmill or any kind of exercise. You need medical clearance or ask them to visit their physician and consult them before landing into any kind of exercise program. So it is empirical to take resting blood pressure a few times at rest, identify the range, and make sure that this person is either fit or not fit to do the exercise. That was the aim of highlighting the American Heart Association classification, to let everybody know different ranges and what are the values which suggest flag sign for stopping exercise or consulting a physician. Now, blood pressure is something which depends upon a lot of factors. These are some of the factors. These are, of course, not all the factors. These are some of the important factors which I felt are important, and I've highlighted them, and I'll talk really, really briefly about them. Hydration is important. If your hydration is less, your blood volume is less, which decreases the cardiac output, and your systolic blood pressure is less, decreasing the overall blood pressure. So you want to be hydrated to avoid hypotension or low blood pressure. Gender is a very interesting thing. I just don't want to go into the details, but you just have to remember that before the age of 40 or menopause, females have less blood pressure than males. Males have higher blood pressure because of the absence of estrogen, or we can say the presence of estrogen in females save them from high blood pressure. But after 40, as estrogen level decreases in females, they are likely to cross men as far as the hypertension is concerned. And in the later ages, maybe in the 60s and 70s, females have more hypertension and cardiovascular events than males. Muscle actions, if you do exercise, it stimulates sympathetic nervous system and your blood pressure is bound to increase. Stress is an important factor. So if you are stressed, it stimulates all hormones which stimulate blood pressure, whether it's the catecholamine, the epinephrine, and the norepinephrine, or it's the cortisol. All of these hormones, they just stimulate sympathetic nervous system, increases your blood pressure. Diet, yeah, once you take food, or if you are on a high carb or fat diet, because of increased metabolism, a lot of hormones stimulates and they increase blood pressure. Diseases, the cardiovascular and the cerebrovascular diseases are the two big diseases in which the blood pressure is elevated. I want to talk about body position, and I've highlighted it in a red circle because the effect of body position we are going to discuss in the later half of our practical today. But just be aware that with change in body position, blood pressure changes, and that happens because of the effect of gravity. If you are lying straight, supine, everywhere, the gravity is acting on the blood column at an equal pressure, so it's equal everywhere. But if you change your position, let's say from supine to standing, then more blood pools into the lower limbs because of the action of gravity, and you have high pressure in your lower half of the body, low pressure on the upper half, and it has consequences before different mechanism creeps in. So change of body position has an effect on blood pressure due to gravity. Now, continuing the discussion from the previous slide, this change in blood pressure, if you change your position from lying to standing, is known as orthostatic hypotension or lightheadedness. I guess you guys have noticed a lot of times, that once you are sleeping, lying for a long time, you just get up and you'll see a episode of a kind of a blackout, or you feel that you're going to pass out because everything is black. This condition lasts just for a couple of seconds, maybe for some people for 10 seconds, and then you slowly see everything is getting normal because the body's compensatory mechanisms, they just started to work. So this change in blood pressure due to position is known as orthostatic, which is the change in position. Hypotension is less blood pressure. Okay, so these is some of the details about it. So if a person has a change of SBP of 20 or a decrease of DBP of 10 within 3 minutes of standing, then that person may be diagnosed as orthostatic hypotension. That person is in a state of orthostatic hypotension. And the problem is that the baroreceptor mechanism is not working. I just want to spend maybe a 30 or 40 seconds on what baroreceptors are. Of course, this is not the topic for discussion today, but these are the receptors which sense the blood pressure change. And the idea for them is to set the blood pressure to a normal point. So if your blood pressure is high, they just try to bring it down to normal. If your blood pressure is low, they just try to elevate it to normal. So once you change your position from lying to standing, the blood pressure decreases because everybody settles down in your lower limbs. And at that point of time, these baroreceptors get stimulated and they try to elevate blood pressure. They try to do it in just 30 seconds. And that's why you feel that your blood pressure is getting normal in 30 seconds. But in case that these receptors are not working due to some pathology or hypertension or some kind of autonomic nervous system disease, in that case, the blood pressure will not become normal and you will have those episodes of blackout or passing out real quick. All right, now we are slowly making a transition from the theory of blood pressure to what we are going to do in the lab. And this slide is exclusively meant for you to know that before taking blood pressure, you want all these measurements to be really taken because these factors can affect blood pressure. And if you won't take them into consideration, you may have an erroneous kind of a recording. The first is wear loose clothing because any kind of tight clothing will have increased peripheral resistance, increases blood pressure. You don't want anybody to do exercise. You want to avoid any sympathetic stimulation. The person has to be hydrated. I've already talked about hydration. Avoid persons sitting cross-legged because that again increases peripheral resistance and increases blood pressure. And the environment should be stimulus-free, which means it shouldn't be very cold or very warm because you want an ambient temperature to have the right recording of blood pressure. Although it's not written, but you want to avoid all kind of smoking, alcohol intake, caffeine intake, anything which stimulates the cardiovascular system or the sympathetic nervous system in particular, you want to avoid before taking blood pressure. Now, this is the big instrument which we are going to use for taking blood pressure. This is known as sphygmomanometer. This instrument is used along with the stethoscope, which we have discussed in our last lab, to take blood pressure. And I wrote some of the very key points regarding this instrument because I want everybody to be aware of this instrument, the parts of this instrument, how they work, so that you should be comfortable in taking blood pressure. So it consists of an inflatable rubber tube. So the tube which we are talking about here in the first line is a tube which is inside this blue stuff. We cannot see that, but there is a rubber tube. And this rubber tube actually inflates and impedes or occludes the artery. And this blue thing which you are seeing here is a kind of a covering which is known as cuff, and that cuff we are going to tie on the arm. So this is known as the typical blood pressure cuff. But remember that there is a rubber tube inside it which inflates once you pump it through this bulb. Now, this black part is just a Velcro so that this cuff can be tied. Then there is a hand air pump which contains an adjusted knob. So we are talking about this pump, and it has this adjusted knob. So if you lock it and press it many times, it will pump air directly into this rubber tubing which I talked briefly at the beginning. Then you have this meter or type stuff which is known as the manometer, which actually has readings up to 300 mm of mmHg. I've already talked about the cuff. These are some of the measurements. In our lab, we have three cuff sizes. The first one is small, the second one is medium, and the third one is big. So the idea for you is to put the cuff on your patient or subject's arm, and you make sure that the rubber part inside it covers at least 40% of the circumference of arm. Then that cuff is an apt stuff. If it's not covering 30%, this is not the right cuff. It will not occlude the bladder, the vessel, the brachial artery properly, and you may have incorrect readings. So make sure that you are using the right cuff size. If you still have any questions, I'm more than happy once I'm demonstrating in the lab and once you guys are performing in the practical. Right. Now, we can measure blood pressure using the palpatory method and the auscultatory method. I want to discuss it in some detail here, and I wrote every step which you have to follow. We have a video at the end as well, and we will practice. So believe me, you will be able to take blood pressure really easily once you try these two methods and follow these steps methodically. Now, always make sure that the person is either sitting or lying comfortably. Ideally, you want this arm to be lying at the level of heart. So if the person is lying, of course there is no issue. But if the person is sitting, you make sure that the arm is rested on the chair, and it should not be hanging like this. You don't want any resistance to be increased. Now, these are a few points which you want to pay attention because these are checked on your practicum skills. Once you are tying the cuff, you make sure that it is approximately 3 centimeters above the antecubital or the cubital fossa, because you want apt or appropriate space to put the diaphragm of the stethoscope. Now, the brachial artery comes under the middle of the cuff. So if you see the cuff, there is an artery marker, and you want that artery marker to be somewhere here where you have palpated the brachial artery. Sometimes it's possible, sometimes people do that, they mark a point once they palpate the brachial artery and try to put the pointer which is marked on the cuff just on the side so that they have put the cuff on the right place, and once it gets inflated, it will occlude the artery. Then the tubes are directed inferiorly. So this is a great important part of the diagram, that all these tubes, whether it's the tube connected to the manometer or the hand pump, should be directed inferiorly and downwards, not to the other side. And the cuff should not be neither too tight nor too loose. This is a ambivalent or just, ambiguous term. So the idea is that it should not be too tight that it occludes the arm, and it should not be too loose. So you try to insinuate your fingers once you tight the cuff. If you are not able to do that, it means it's too tight. If you're easily able to do that, it's too loose. And if you just put the fingers with a bit of a resistance, this means that it is tied at the right strength, I guess. Now, once the cuff is tied, you're all set. You just try to palpate the radial artery, by which, with the technique we have discussed in our previous practical. And with one hand on the radial artery, and with the other hand, you can start pumping the air bulb, and then you will feel that at a point the pulse disappears. So the point where the pulse disappears, which means that it has stopped. Now you try to deflate the manometer, and a point comes where the pulse reappears. So you're palpating the pulse, inflating the air bulb, pulse disappears. Just stop there, or maybe pump a couple of times and try to move the dial to decrease the pressure in the manometer. The moment the pulse reappears, this is the point which is the reading of systolic blood pressure, and just immediately release the cuff. So if you want to take 3 points out of this palpatory method, first, you are not using stet because it's a palpatory method, you are palpating the pulse. Second one, we can only measure systolic blood pressure by this method. And the third one is you try the blood pressure cuff, palpate the radial artery, inflate the cuff, deflate it, the point where the pulse reappears, highlighted in red, that's the reading of systolic blood pressure. All right, we are all set for the final discussion, the most important one. So gear up and just don't try to get tired, because we are just moving towards the end of the practical. This is the most important skill. Blood pressure measurement by auscultatory method. Now the good thing is that for all the first few steps, up till the point of tying the blood pressure cuff, up till the point of palpating the artery, everything remains the same. The difference is that, as the name suggests, it's an auscultatory method. So now you have to listen to something. And here your stethoscope comes handy. So you first tie the cuff, palpate the radial artery, and now put the diaphragm of the stethoscope on the antecubital fossa, the space which you have created by tying in the cuff 3 centimeters above. And then you have the systolic blood pressure range in your mind from your previous palpatory method. Let's assume it's 140. So after tying the screw of the sphygmomanometer, you just inflate 20 to 30 mmHg above the systolic range. For example, just as I've said, if we got a reading of SPP as 140, inflate it up till 160 or 170. At that point, put the stethoscope here, put the earpiece in your ears, and listen to the sounds very carefully. You can't hear any sound at that point. Try deflating the deflating the sphygmomanometer screw, and try to deflate at a rate of approximately 1 to 2 mmHg per second, and try to listen to the sounds. A point comes when you hear a slow sound. The point at which the sound appears is the reading of systolic blood pressure. And as you continue deflating, the sounds becomes louder, and just continue doing it. And a point comes where that loud sound becomes slow, muffled, and it disappears. The point at which it finally disappears is your reading of diastolic blood pressure. I am again repeating it. The point of appearance is systolic. The point of disappearance is diastolic. And before moving further, I want to revise this auscultatory method once more. Try the blood pressure cuff. Great. Put the stent on the brachial artery. Try to inflate it more than 20 mmHg above the systolic range, which you found in the palpatory method and try deflating the screw at the rate of 1 to 2 mmHg per second. The point at which you hear the sound, that is systolic blood pressure. And the point at which the sound disappears is your diastolic blood pressure. And by the way, it's written on your slide that these tapping sounds which you hear are known as the Korotko sounds. It's on the name of the person who has discovered these sounds. So this is how you take blood pressure using auscultatory method. And for you to recapitulate this whole story, we have a couple of videos. You can definitely see them. They are really good. The first one, it will tell you the technique which I just described. The second one is a kind of an examination where you listen to this video and try to identify that at what point you're hearing the systole and the diastole. So it's a kind of a practice video. And we are going to do it again and again in our lab today and in the coming practicals where you have to maintain that BP log. So we will make sure that you take blood pressure in every lab, no matter which practical you are doing, just to practice it a lot, because it's an extremely essential skill to learn as far as the exercise testing and prescription lab is concerned. So we have summarized some of the key things today: the importance of blood pressure, what is the definition of blood pressure, a lot of key terms including systolic, diastolic, pulse pressure, mean arterial pressure, cardiac cycle. Then we discussed the two important methods which I tried to explain in detail: the palpatory and the auscultatory methods to take the blood pressure. And what are the PP takes place once you change your position. That's where we talked about the orthostatic hypotension, which is the change of blood pressure with position due to the effect of gravity. And the last thing I want to discuss is this data sheet 4.1. So once you are there in the lab, enter your basic details, the age, the height, and all the weight. You can ignore the temperature and the relative humidity if the time won't permit. Now, this is the blood pressure measurements which you're going to take. So the idea is that first you take the blood pressure in a sitting position, supine position, initial standing position, and more than 2 minutes of standing. So first you take in the supine position. First go for trial 1, take the heart rate, put the blood pressure here, the first reading and the second reading, take the mean. Just ignore this last row of ST because the time is less and I just don't want to indulge into standard deviation calculation. So the idea is you take blood pressure in supine position, then you make the person sit, take again the systolic and diastolic blood pressure twice, then make him standing from the sitting position. Ideally, you will see a drop in the blood pressure because of the effect of gravity, and then you take blood pressure after 2 minutes, and at this point, we should assume that the bioreceptor mechanism will bring the blood pressure back to the normal. So these are a lot of blood pressure readings which you're going to take once you're in the lab. I guess we got something out of this discussion, and these are the skills which you need to be you want to do professionally as well as skillfully during your practicum, and you will be tested on these skills. So I have exactly mentioned them so that there shouldn't be any confusion about them. If you have any questions regarding these skills, you're more than welcome to ask me during the practical or afterwards. I hope you'll get something out of this lab, and I hope to see you there when we are going to practice our skills. Great. Thank you very much.